Bye, guys.
Thank you, Marina. Thank you, Luis.
Hi.
Can you hear me?
Yes.
Well, it's my pleasure to be here today and to chair this session. And I am replacing Lorenzo Spaggiari. And now we are moving to discuss a different setting of disease, the early stage of treatment in non-small cell lung cancer, in which I hope and I think that we can obtain some gain in survival. At least the data are very encouraging on this. And we have two very important speakers that will afford the question of the treatment in the early stage. And we start with Shiri Kajel from Ann Arbor. Shiri has been already participated a lot in this meeting. And he will address the question of the neoadjuvant and adjuvant treatment in the era of the immunotherapy. Shiri?
Thank you very much. Do you hear me?
Yes.
Yeah.
Okay, thank you. Thank you, Dr. Crino. And again, like to thank the organizers for inviting me. Again, my conflicts of interest. And as Dr. Crino mentioned, it's truly exciting to now discuss immunotherapy. We have been discussing immunotherapy first in the second line, then in the front line with advanced disease. But now we have data in the perioperative setting, and it is quite possible that that's where immunotherapy may have the greatest benefit. I think it's always good to remind ourselves why adjuvant therapy or systemic therapy in early stage lung cancer is relevant. This is from a review paper I wrote with my mentor, Dr. Wozniak. And even with the older data, even when you look at stage 1A disease, the top row, the 5-year survival is only 61%. If you look at stage 1 breast cancer, it is usually more than 90%. And the primary reason these patients pass away is because of recurrence, primarily distant recurrence. And this is quite remarkable considering that many of these patients are older and have comorbidities such as COPD or cardiac disease. And despite that, lung cancer is the most important reason for their deaths. Clearly, there is greater risk of distant recurrence in advanced disease. But important to recognize that even in stage 1A disease, a significant minority of patients have already systemic micrometastatic disease, which cannot be managed with local treatment. We all know adjuvant therapy provides benefit, and I feel that sometimes the benefit of adjuvant chemotherapy is somewhat understated. When everybody quotes the meta-analysis that showed a 5% 5-year survival improvement. However, when you look at the two, what I call modern adjuvant trials that evaluated cis-mineralbine, the ANITA trial conducted in Europe, and the JBR10 trial led by the Canadian group, the survival advantage is more in the range of 8 to 10%. But more importantly, it is quite critical to note that in patients who have lymph node disease, the benefit ranges from something like 15% to 20%. So unlike breast cancer, in lung cancer, the benefit does not result in proportional reduction across all stages. Clearly, the benefit is greater in a more advanced early stage disease, if I may say that, as compared to stage 1 disease. So clearly, the benefit is modest with adjuvant chemotherapy, but one needs to be mindful that the benefit does vary according to stage. And maybe with modern therapy, it is closer to 10% than 5%. Nonetheless, the benefit is very modest. So the tradition has been to do adjuvant chemotherapy because surgery for many years, I would say 30 to 40 years, remained the only curative treatment. And so there was reluctance to start off with a treatment that was not felt to be curative. But there are studies that have looked at neoadjuvant therapy, and I've briefly listed the pros and cons. Dr. Ramalingam did an excellent job discussing this issue yesterday when he discussed targeted therapy, neoadjuvant targeted therapy. I've listed some very simple things. There may be improved tolerability of administering systemic chemotherapy before surgery, possible downstaging, early treatment of micrometastatic disease. The concern is, would it impact the only known curative treatment for many years, surgery, and would it increase post-surgical complications? Neoadjuvant trials have been conducted, and the meta-analysis of these trials shows that the benefit is very similar to what has been observed with adjuvant chemotherapy, with 5% improvement at 5 years. There are very small number of studies that have looked at both neoadjuvant and adjuvant chemotherapy in the same study. The Spanish trial led by Dr. Philip is probably one of the largest. And what they showed, this study actually did not show a benefit to perioperative chemotherapy, probably because there were a lot more stage 1 patients in this study and a lot fewer, a very small minority that had stage 2 and stage 3, where there's clear evidence of benefit from adjuvant therapy. But despite that, what was noticed is that the benefit with the outcomes with neoadjuvant chemotherapy were very similar to adjuvant chemotherapy. And most importantly, neoadjuvant chemotherapy did not impact the ability to perform surgery or increase post-surgical complications. So studies that have compared neoadjuvant chemotherapy to adjuvant chemotherapy suggest that the benefit may be similar without compromising any outcomes. Now, the question is, how does this now relate to immunotherapy? With all the data that has been generated with immunotherapy in advanced stage disease, there's clearly interest in moving this treatment into earlier stages of lung cancer. And the question is, what is the best approach? Is it better to do neoadjuvant immunotherapy or adjuvant immunotherapy? And again, there are theoretical pros and cons regarding this approach. There may be a greater release of tumor neoantigens leading to better response by the immune system. There's intact lymphatics and lymphatic structure that may be damaged with surgical intervention. And again, the issue of early micrometastatic disease. As far as the cons, clearly the concern about delayed surgery, whether surgery would be challenging after neoadjuvant chemotherapy, and of course the concern of induction of immune-related AEs, whether that would impact not just surgery, but the post-surgical course. There is some preclinical data that suggests the neoadjuvant approach may be better than adjuvant chemotherapy. Now, this is preclinical mouse models that looked at both a single agent PD-1 inhibitor versus as well as PD-1 plus a 4-1BB agonist. And they looked at both neoadjuvant therapy versus adjuvant therapy in the same tumor model. And consistently what they found was the outcomes in the animal models were better with neoadjuvant chemotherapy, rather immunotherapy as compared to adjuvant immunotherapy. This was both with single agent PD-1 as well as with the combination, and was seen in 2 different breast models. So this was not a lung cancer model. And their hypothesis was that the presence of the tumor before administering immunotherapy may allow a greater release of neoantigens and greater activation of CD8 T cells. But more importantly, they observed a greater activation of memory T cells with the neoadjuvant approach. Now, whether that is going to be necessarily relevant in the clinical setting remains to be seen, but at least this study suggested that neoadjuvant approach may be beneficial. There have been several single agent as well as combination IO neoadjuvant studies conducted. These are more sort of exploratory studies. This was one of the first that was reported by Dr. Ford and colleagues from Johns Hopkins and Memorial Sloan Kettering that evaluated nivolumab in early stage non-small cell lung cancer. This was published in the New England Journal of Medicine. The primary endpoint actually was feasibility. That is, they wanted to ensure that neoadjuvant 2 doses of nivolumab did not impact the ability to perform surgery in these patients. There was 1 death in the postoperative safety period, but this had nothing to do with the treatment or the lung cancer because it was related to the fall. And when you look at the toxicities observed with nivolumab in this study, they were to a large extent what one would expect. They found a major pathological response an endpoint that is defined by less than 10% of viable tumor cells in the resected specimen in about 43% of the patients. They found that there was greater correlation with TMB and the major pathological response as compared to PD-L1, baseline PD-L1 expression. Again, small number of patients, very difficult to make a lot of conclusions from such a study, but nonetheless shows the feasibility and the possible benefit with neoadjuvant immunotherapy. A larger study with single agent PD-1, PD-L1 inhibitor was the LCMC3 trial presented at World Lung earlier this year, where atezolizumab was evaluated, again, just 2 cycles before surgery in stage 1B to 3A patients with the option to receive adjuvant atezolizumab. And in this study, the major pathological response was 21%, a little more modest than what was observed in the Dr. Ford study, but this was a much larger population with 159 patients. In this study, unlike the Ford study, there did appear to be a correlation with the baseline PD-L1 expression with a higher response rate, a major pathological response rate, rather, in patients whose tumors were PD-L1 high as compared to PD-L1 low. Most of the other factors were kind of exploratory, again, relatively small numbers, though there was correlation with radiologic response in terms of obtaining MPR, an intriguing, much higher MPR rate in females as compared to males. And pretty much similar MPR rate between N1 and N2 disease. There did appear to be some correlation, and again, this is a very early follow-up of overall survival with major pathological response as suggested by the curves, though when you actually look at sort of landmark analysis, the difference is not significant. And so when it comes to overall survival, there was a trend, a very minor trend with improved survival, a little more pronounced difference in disease-free survival comparing MPR to disease-free survival. So there may be some clinical value in assessing pathological response. Another study looked at the combination of Nivo-Ipi versus Nivo alone. And to briefly summarize the outcomes, there did appear to be a greater pathologic response with the combination compared to nivolumab alone, but this was also associated with higher toxicity rates. Again, extremely small numbers, only about 40 patients. So very difficult to make significant conclusions. But Nivo-Ipi may be associated with higher path response rate, but also associated with higher toxicities. So this was data with immunotherapy alone. What we commonly use in the advanced setting is chemo with immunotherapy. And one of the studies recently published in Lancet Oncology was the Nadim trial that evaluated in patients with resectable non-small cell lung cancer chemotherapy with nivolumab. They used carboplatin paclitaxel because it was histology agnostic, and subsequently the patients underwent surgery and then received adjuvant immunotherapy. The primary endpoint of this study was progression-free survival. The study required pathologic evaluation of the mediastinum, and PET scans and brain MRI were mandatory. The study had a PFS at 24 months of 77%, quite a remarkable PFS rate. And the pathologic response rates, both major pathologic response as well as complete pathologic response, was quite high, or at least appears to be higher than what was observed with single agent immunotherapy. These rates listed in the table are in patients who did undergo surgery. So there were 46 patients who were enrolled. 41 patients were able to undergo surgery. If you look at all the 46 patients that were enrolled on the trial and started on neoadjuvant chemotherapy, The PATH CR rate was 54%, and the major pathological response rate was 74%. There were some grade 3 events observed with chemoimmunotherapy, but all that one would expect with chemoimmunotherapy, none that would not be seen. And some of the other conclusions of the Nadim trial were no patients progressed during the neoadjuvant therapy, because that is clearly a concern that we are delaying a curative treatment. Surgery was not delayed due to treatment-related AEs. Overall survival at 24 months was 90%. And the post-operative complication rate was 29%, but it was felt not much different than what would be expected with surgery upfront. Now at AACR this year, Dr. Ford presented the first randomized data evaluating immunotherapy in the neoadjuvant study. This is the Checkmate 816 trial that enrolled patients with stage 1B to 3A. This is according to the TNM version 7. Patients were randomized to Nivo chemo versus chemo alone. This was not placebo controlled. And then patients underwent surgical resection with an optional plan to do adjuvant chemotherapy with or without radiation. The patients, there were a good number of patients. This was almost a 400 patient trial. The baseline characteristics were well matched and expected of what one would see in resectable population. Important to note that compared to advanced stage disease, the proportion of squamous cell patients was higher in this early stage trial. There were two primary endpoints of the trial, event-free survival rate as well as complete pathological rate. The data that was presented at AACR just discussed the complete pathological rate. The event-free survival rate has not yet been presented. And what the investigators observed, that there was almost a 14-fold increase in the PATH-CR rate between patients who got neoadjuvant chemotherapy versus patients who got Nivo plus chemotherapy. And this was, as expected, somewhat higher in patients who underwent surgical resection. When you look at the forest plots as to the patients who had a greater chance of pathological CR rate with Nivo chemo, pretty much all populations benefit, as has been observed with other immunotherapy trials. The benefit appeared somewhat less in never smokers. But when you look at all the factors, including PD-L1, including TMB, clearly there was a greater pathological CR rate with the combination of Nivo chemo. Treatment-related AEs were very similar to what we would expect with chemo IO. And then at this year's ASCO, so Dr. Ford presented the primary analysis at AACR, but at ASCO, Dr. Spicer presented the surgical outcomes from the study. And what is quite important to note is that there was no delay in surgery in the Nivo chemo arm versus the chemo arm. And in fact, there was a greater probability of performing minimal invasive surgery in patients who received chemo plus IO as compared to patients who received chemo alone. Also, it did not lead to increased surgery-related AEs. There's this perception among surgeons that there's greater fibrosis in patients who have received a preoperative immunotherapy, but at least this didn't translate into increased post-surgical adverse events. Now, as I mentioned, one of the primary endpoints was pathological CR rate, but what is the true clinical relevance? We looked at in the Nadim trial that there may be some correlation. This is a meta-analysis that was presented at ESMO in 2020. And looking at the neoadjuvant trials of chemotherapy or chemoradiation treatment, concurrent chemoradiation, there does appear to be a correlation with pathological CR rate and survival, as well as MPR rate and survival. Now, it remains to be seen if regulatory authorities will be willing to accept this as an endpoint. At least in the US, they have accepted this for breast cancer But there is a lot more history of doing neoadjuvant chemotherapy or hormonal therapy in breast cancer, and whether that will translate into lung cancer remains to be seen. There are several ongoing neoadjuvant trials at the present time, and I think this totality of data will truly define the role of neoadjuvant immunotherapy, particularly in combination with chemotherapy. Moving on to adjuvant immunotherapy, and I feel we already have some data in this regard. Now, no one would consider the Pacific trial as adjuvant therapy, but conceptually it is using immunotherapy following definitive treatment for locally advanced disease. And at this year's ASCO, Dr. Spiegel presented update from this trial, and the survival advantage with the patients who received durvalumab holds up. Now at 5 years, 10% improvement in survival with the use of consolidation durvalumab, and similarly an improvement in progression-free survival of about 15% at 5 years. At this year's ASCO, I believe this was the only presentation that should lead or probably will lead to change in standard of care, was the Empower 10 trial that randomized patients with resected stage 1B3A following adjuvant chemotherapy to atezolizumab or best supportive care. So this study enrolled patients following surgery before receiving adjuvant chemotherapy. It was mandatory that the patients received cisplatin-based chemotherapy. Carboplatin-based adjuvant chemotherapy was not allowed. And following completion of adjuvant chemotherapy, patients were randomized to atezolizumab or best supportive care. 1,280 patients were enrolled, of which 1,005 patients were randomized. I'm quite impressed that they were able to randomize 1,005 patients. The primary endpoint was investigator-assessed disease-free survival in PD-L1 positive stage 2 and 3A. And then subsequent, if that endpoint was positive, they had hierarchical testing. And what was observed is that the study did meet its primary endpoint with an improvement in event-free survival with a hazard ratio of 0.66 that translated at 3 years of a 12% improvement in event-free survival. They subsequently assessed the benefit in all patients with stage 2 and 3A, irrespective of the PD-L1 status, and the survival advantage held up now with a narrower hazard ratio of 0.79. But when you look at the data, the forest plot, it appears that the benefit is restricted to PD-L1 positive patients. And really, you don't see a benefit to PD-L1 negative, not too different, though this was not a planned analysis in the Pacific trial. The benefit was clearly less in Pacific trial in the PD-L1 negative patients. In addition, the benefit appears to be much more in PD-L1 high patients, and it remains to be seen if the benefit observed in PD-L1 positive is primarily driven by the PD-L1 high, and it would be at subsequent presentations, I understand they're going to present the benefit in 1 to 49 patients. They also looked at subsequent disease-free survival in other populations and as well as overall survival rather. And no benefit as yet has been observed, but this is an extremely early analysis. Toxicities were what one would expect. There were 18% of the patients who discontinued treatment due to adverse events. And so one needs to be mindful that 1 in 5 patients cannot complete this treatment. There are several other studies evaluating in US. Cooperative group study has completed enrollment, randomizing similar study to nivolumab versus standard of care. And our Canadian colleagues are conducting a study with durvalumab in a similar setting. The ongoing adjuvant trial in US, the cooperative group trial, is evaluating the combination of chemotherapy plus immunotherapy and randomizing patients to chemo alone, followed by observation, or chemo followed by immunotherapy, or chemo immunotherapy followed by consolidation immunotherapy. So in conclusion, adjuvant atezolizumab has improved disease-free survival in PD-L1 positive stage 2 and 3A patients following surgery and adjuvant chemotherapy. Neoadjuvant chemotherapy and nivolumab improved pathological CR rate in the CheckMate 816 study. There are several studies that are assessing both approach, but I think that is going to be critical more so than in advanced stage setting, that we truly identify the patients that are most likely to benefit with immunotherapy, and therefore investigations of biomarkers is extremely critical. Thank you very much.
Thank you, Shirish, for your very updated presentation, very clear. And I think that we can have the discussion after the presentation of Luis Pasares from Madrid. And you have mentioned the Pacific trial. Luis will address the topic of the treatment in the locally advanced non-small cell lung cancer. Please, Luis, are you here?
Okay. Yes, yes. So thank you. I think I'm just putting the presentation 1 second. It's going to be there.
Yeah.
Okay. Are you able to see that already?
Yeah.
Okay. So thank you very much, Crino, for the presentation. Thank you to the organizers for having me there, even virtually this year. And congratulations, Shirish. Very nice presentation. Actually, I'm actually restricting for my talk to the more unresectable patients, because I thought you will deal with the neoadjuvant treatment for more resectable patients. So here are my disclosures. And of course, if we look at stage 3 patients, we know that there is a range. This is a heterogeneous group of patients, including stage H, stage 3B, and 3C. And of course, some of them, particularly stage 3B and C, for most of the cases are unresectable, but also some of the stage 3A. And of course, the approach is going to be different. And I think Dr. Gatchel had already dealt very well with the resectable part, particularly for those patients with 3A. Most of the neoadjuvant approaches are actually focusing on that patient population, particularly most of the benefit is there, looking at the Nadine trial and the more recent chemo-nivo trial, the phase 3 trial. In terms of a resectable disease, this is going to be the focus of my presentation, and typically patients are treated with possible chemoradiation. If the patient is frail or functionally is not candidate for chemoradiation, may have chemo first and then chemoradiation. In cases of worst functionality, worse health, maybe the patient is treated with chemo followed by radiation on a sequential approach or radiation alone. And you see here that for many years, we know that overall survival is much better with chemoradiation given concurrently as compared to the sequential approach. And of course, if you're using conformal radiation, that is going to be better as compared to the radiation. This is not only in OS, but also in toxicity, particularly you're using some technologies such as IMR3, where you're really decreasing the rate of pneumonitis, esophagitis, and so on. Over the last decade or so, we tried to improve the results in this setting, not quite successfully so far. Of course, looking at the data, long-term survivorship is in the range of 20%, 25%. So there is clear unmet need here. Of course, I mean, the increasing the doses above 60 grays of radiation during the concurrent treatment is not worthy at all. You see here the results actually showing that those patients with higher doses were actually doing worse as compared to standard of care of 60 grays. Alternative chemotherapy schedules such as the system are not better, maybe not worse, but not better as compared to the standard platinum etoposide. And the use of targeted therapy as consolidation, the cetuximab trial for the AIOT didn't impact on survival either. So there is a clear unmet need, and that reason actually justified the initial use of immunotherapy in this setting. Indeed, we have done some immunotherapy trials in the past, and I'm pretty sure that you remember some of those trials, such as the MOTAI trial, where a good number of patients were included, showing that after chemoradiation, those patients actually treated with concurrent treatment maybe were getting some benefit as compared to those patients with the sequential approach, where the benefit over a placebo was not clear. Of course, that was a secondary analysis, and the trial was never validated in a subsequent trial. Well, after seeing the data with the chemo with the PD-L1 and PD-1 agents in the advanced setting, also analyzing the clear synergism effect between PD-L1 inhibition and other agents such as radiation therapy, facilitating the priming of the immune response, not only on stage 4, but also in some experimental models in much earlier disease. That trial, the Pacific trial, was set up, comparing in those patients with locally advanced disease, unresectable, that were receiving chemoradiation, maybe chemo followed by chemoradiation, but in any case, a chemoradiation. If no progression happens at the end of the treatment, those patients were randomized to receive durva versus placebo, durva to be given for a year. And remember that randomization had to be done within the next 6 weeks after the last dose of radiation. The trial was well balanced, similar number of patients, very similar characteristics. Remember, half of the patients stage 3A, half stage 3B, half squamous, half non-squamous. And again, half of the patients having a response to chemoradiation, half of the patients having a stable disease. You see, or you remember the initial analysis, hazard ratio for PFS 0.52, decrease in the rate of progression over time of 50%. You look at the site of progression, it was very clear that there was a decrease on intrathoracic progression, but also in extrathoracic on metastatic progression. In both cases, the hazard ratio in the range of 0.4, 0.5. So that was not only at the local or regional level. Here is the 5 years update, really impressive result. Look at that at the 6 years later after starting the durvalumab treatment, PFS being 19% on the placebo arm as compared to 33% on the durva arm. That means nearly doubling the number of patients being progression-free at 6 years. Overall survival, our data are very consistent. So there is an increase at 5 years survival of about some 1/4 from 34 to 43%. And I think those data are really impressive as well at 6 years. Responses were also improved, and not only response, but duration of response, as you may understand for the PFS and OS data. Looking at the safety side, there was no big issues in terms of safety. Similar data in terms of grade 3/4 tox, leading to discrimination, 15% of the patients in the durva arm as compared to 10% in the durva plus treme. And maybe the only difference was in the rates of immune-related adverse events, 24 as compared to 8%. Of course, always higher in the durva arm. Looking at specific items, you can see the general type of side effects were very similar in both sides, but when looking at those more typically drug-related, you see that they were more frequent in the durva arm, such as the case for hypothyroidism, rash, pneumonia, pyrexia, pneumonitis of coughing. You look at the important, maybe most important side effects, pneumonitis. There was an increase in the rate of pneumonitis, 34 as compared to 25% in the durva arm, but for most of the cases, they were grade 1 or grade 2. Grade 3 or grade 4 were only 3.4% in the durva arm as compared to 2.6%, and there were no difference in terms of toxic deaths. The other important dimension of the result of the treatment is quality of life. Looking at the patient-reported outcomes, as you see here, very similar outcome for patients treated with durva as compared to placebo. You didn't expect here to see kind of an increase in symptomatic improvement, as because most of the patients at the end of chemoradiation wouldn't be symptomatic from the disease. So the concern was mainly toxicity and symptoms derived from side effects. And you see here that there was not a major impact. The same was true when looking at physical functioning and global health status. No difference all along the study period. The final issue was when looking at which patients were benefiting the most, and it was very clear that for most of the analysis, all the patients subset were benefiting. That was true in terms of PFS, that was true in terms of OS, regardless the chemotherapy that was used, if patients were receiving or not a chemotherapy before chemoradiation, if patients had a response or disease stabilization to chemoradiation, and so on. A significant point was that those patients that were started on durvalumab within the next 2 weeks after chemoradiation, maybe they actually derive higher benefit as compared to those patients that started between week 3 and 6. That was true for PFS, and of course, that was true for OS. The more controversial analysis, as you're aware of, is the PD-L1. Looking at the PD-L1 status for PFS, the initial analysis was set up with a cut point of 25%. However, the requirement of the agencies was to analyze also the cut point of 1%. You see here a clear benefit for patients with PD-L1 more than 1% in favor of durva, but also for those patients that were not expressing PD-L1. Maybe the hazard ratio was a bit better, 0.46 for positive expressors as compared to negative expressors, 0.73. However, when you analyze the OS, the data were still positive for PD-L1 positive patients, but they were not any more positive for PD-L1 negative patients. Of course, here what was a bit more strange were the performance of the placebo arm, with more than 60% survivorship at 5 years among the PD-L1 negative patients, as compared to survival of 40% on the same patient population being, on the same treatment arm placebo, when the PD-L1 was higher than 1%. So that was maybe a question if that was an overperforming or not the placebo arm. There were some other trials. Here is the pembrolizumab trial by the Husser group using a pembrolizumab after chemoradiation in patients that didn't progress to chemoradiation. Very similar response. Look at that. PFS at 3 years in the range of 40%, survivorship at 3 years in the range of 50%. Super impossible results across trials with the Pacific trial. So what are we doing and what are about to do in the post-Pacific era? Well, there are a number of things that we are interested on, and we have to provide answers. One of the first things is what happened to those patients with stage 3 unresectable disease that are not candidates for chemoradiation. Thank goodness there are a number of trials that are looking for durvalumab after sequential treatment with radiation for those patients that had not been candidates for chemoradiation concurrently as well. And there are a couple of trials, Pacific 5 and Pacific 6. Another relevant trial is about duration of immunotherapy. And there are some of the trials that are actually looking about 1 year or 2 years of treatment after chemoradiation. A significant one is, well, the preclinical data suggests that the earlier you start with PD-1 inhibition, maybe the better the results. And indeed, some of the trial are actually looking at that concept. This is the Nicholas trial where patients were receiving 1 chemocycles and then chemoradiation plus nivolumab. And as you see here, some 60% of the patients were actually progression-free some 12 months later on. Indeed, the rate of pneumonitis was a bit higher than 30%, being grade 3 or so in some 10% of the cases. A parallel trial with pembrolizumab was with atezolizumab was the third trial, where in 2 parts, so concurrent chemoradiation followed by chemo plus atezo and then atezo, and in the part 2 they use concurrent chemoradiation plus atezo from the beginning, and there's consolidation with chemo atezo 2 cycles and then atezo. So concurrent chemoradiation atezo from the beginning, or just starting chemoradiation and then consolidation. As you see here in part 1 and part 2, the results were pretty promising, particularly in terms of OS in the concurrent approach. You see here at 2 years, some 80% of the patients being alive, and PFS in the range of 40%. In that case, the toxicity was very, I would say, comparable to what we have seen in the prior Nicholas trial. That is the other trial using, in that case, pembrolizumab, 2 different cohorts, non-randomized trial. One is using chemotherapy with carbotaxol plus pembro, using radiation after the initial course as well. In the second cohort, again, 1 cycle of chemo, pimeterset plus cisplatin, and then pembrolizumab plus platinum pimeterset with concurrent irradiation, and in the 2 cases, a maintenance pembrolizumab for a year. You see here that the results are pretty close to what we have seen with the other trials. Response rates in the range of 70% for the 2 chemotherapy regimes. Remember, the pimeterset chemotherapy was for the cohort B, non-squamous histology, while those treated with carbotaxol were squamous or non-squamous in the cohort A. At some 12 months, PFS was in the range of 70%, and in those patients in both cohorts, and survivorship was in the range of 80 to 90%, particularly a bit better in the second cohort in the non-squamous. In that trial, the grade 3 events were not outstanding, but still relevant in the range of 8% in both cases. But in the cohort A, actually mostly in squamous cell carcinoma patients, there were a number of pneumonitis, and in some 4 cases, those adverse events led to toxicity. That nicely didn't happen on the non-squamous cohort, and they may be caused for the fact that those squamous histology patients tend to have central tumors, larger tumors, and maybe that was part of the issue. Importantly, we are now evaluating these approaches of concurrent chemoradiation plus immunotherapy at the same time with PD-L1 or PD-1 inhibitors. One example is the Pacific trial comparing durva plus chemoradiation as compared to chemoradiation alone. Of course, here the control arm is not the Pacific trial. A similar design is here on the Checkmate 3L using pembrolizumab in the 73L, where with nivolumab, where patients are treated with chemoradiation plus nivo as compared to chemoradiation alone. And then, as you see here, patients at the end of the day are given in the arm A ipilimumab every 6 months, only nivo in arm B, and durvalumab maintenance is given, of course, in arm C, where they are only using the sequential approach, the Pacific regimen. Finally, I'd really like to mention you this trial, the bintrafast, where chemoradiation is given with bintrafast, which is a bifunctional protein inhibiting PD-L1, but on the other hand, trapping TGF-beta. That is a very interesting concept in this context, because you're not only inhibiting TGF-beta signaling in the tumor cell, in the microenvironment, which is an important immunosuppressive signal, but also is a very relevant antifibrotic treatment, as has been shown in a number of other conditions. And you're comparing that again to the chemotherapy, chemoradiation followed by the durvalumab arm, the Pacific trial. So I think it's a nice design, having a standard of care as a control arm, this Pacific trial. Remember that bintrafast is being evaluated as well on stage 4 disease, and there is some early this year there was a press release saying that the drug was not any better as compared to pembrolizumab, but we didn't see the result as yet. Again, there are some other studies looking at this concept of radiation plus immunotherapy that being studied actually in earlier disease stages, such as those patients that are not good candidates for surgery. And this trial with durvalumab is actually randomizing patients with SBRT plus durva as compared to SBRT plus placebo. So just to finalize, let me to summarize on the role of immunotherapy in the context of loco-regional advanced disease. I think durvalumab within the Pacific regime has shown a clear improvement in significant outcomes such as PFS and OS. That is at the cost of very reasonable toxicity, particularly pneumonitis is not being overwhelming in this post-chemoradiation population. With those data in mind, I think we have to really answer a number of relevant questions. What to do if the patient is not a candidate for concurrent chemoradiation? Can we do durvalumab on those patients using sequential approaches? What about if you're using only radiotherapy, not chemoradiation? What happened on early stages by using stereotactic radiotherapy? Is that worth it to also provide here some adjuvant treatment with durvalumab or with other PD-1 or PD-L1 agents? A similar setting in the small cell lung cancer may be the limited stage small cell lung cancer setting, and I think similar approaches to Pacific or even concurrent approaches with chemoradiation plus immunotherapy are also being studied. And of course, we're still searching for novel agents, for novel immunotherapy agents that should be actually introduced as well to the local regional setting of non-small cell lung cancer. So thank you very much. I think that's all for the time being, and I'm very, very happy to answer any questions you may have. Thank you.
Thank you, Luis. And I want to congratulate both the speakers for their very, very comprehensive, very clear outlook on the treatment on early stage of lung cancer. That is something that is moving argument in our clinical practice. I don't have a question from the floor, and I have
a question, Lucio.
Yeah.
Okay. So for the first for Shirish, I have one for Shirish, another for Luis Passares. Luis, good to see you. Thank you for coming.
Thank you very much indeed. Thank you.
Okay. The first question for Shirish. So your presentation, Shirish, is similar to the Macbeth tragedy. So there is the Banco's shadows, and the shadow of Banco is the figure of surgeon, the thoracic surgeon, because we are talking about patients that usually the oncology don't see, because these are patients that arrive directly to the surgeon, and so the surgeon decide to give you before the surgery or after the surgery. So on the basis of the preliminary results that we obtained in immuno agents, immuno and chemo before and after the surgery, what is your opinion about the preference of the thoracic surgeons?
Two things. One is I really like the Macbeth analogy. I'll definitely use that in the future. And then the second thing is I'm never going to sort of predict what the thoracic surgeons will do. But I completely agree with you that this is a complete culture change for thoracic surgeons. They are used to just operating right away when they see early stage lung cancer. What I will say in our experience at our center, and so this is a very limited experience, I have noticed definitely a level of excitement about immunotherapy. That was not, I don't think I observed it with either targeted therapy or chemotherapy. And they in general have been a lot more accepting of us at least discussing neoadjuvant trials. And I can also say that I see over the last 2-3 years, and I'm not necessarily saying that this is because of immunotherapy, that surgeons are more frequently discussing the patients in the multidisciplinary tumor board, even stage 1 patients, instead of just operating and then presenting the operated case and pathology and saying, okay, now do you want to do adjuvant therapy or not? So I am seeing a change. How universal it is and whether it will necessarily take hold is unclear. My sense is, and this is a prediction that I will refuse to honor in the future if I'm wrong, but I really think that we will be moving more and more into the neoadjuvant role, particularly for lymph node positive disease and for patients with large tumors, is my suspicion. I think that there is some hint of downstaging, which was never seen with chemotherapy alone. And I suspect that surgeons would be more accepting. But it's pure speculation on my part, partly based on some observations at my site.
So, Filippo, if you allow me just to share one slide, which is related to a question I've been asked the other day, a similar question, and I just give you my answer the other day. The answer was that the take-home message: times are changing. And I think you know, there is no reason anymore that patients are not coming to be presented to the multidisciplinary team before going to surgery. Honestly, I think those data, but I mean, we are eager to see the event-free survival data, but the data on pathological response are so great. And I don't know if you have had the opportunity to treat patients in some other trials or in the daily practice, but the number, I mean, the responses we have seen here with immunotherapy are actually not comparable to what we have seen in the advanced disease setting. It's just really something else.
Yeah, I agree. My compliments, Luis, for your very complete presentation. I have a question for you. So first, a consideration. Pacific trial is become a standard treatment. So it started as Pacific trial, but now we treat patients following this indication. And this has become a standard treatment. But there is very high the number of patients that don't arrive to receive durvalumab, to receive immunotherapy, because this way is not a very easy way to combine chemo and radio, or also if we can administer sequentially. So there is a high number of patients that risk of not receive an important treatment as immunotherapy for 1 year. So I completely agree with the design of Pacific trial. So in my mind, the goal is to anticipate the immunotherapy for this stage. Your opinion?
No, I fully agree. So, I mean, all the experimental data and the logic is justifying such an approach where you're actually priming the immune response from the beginning. And I mean, those data are also consistent with the neoadjuvant approach, where the earlier you give the immunotherapy, the better. Particularly, you providing that at a time of initial chemoradiation, where we know that the synergism using radiation as a autologous vaccine type of therapy is really great. So I think this is very much
the problem can be represented by the limitation done by the pneumonitis, the pulmonary toxicity of all this combination.
Yeah, so you look at the data, particularly from this Pembro and Atisho trial, the small Nivo trial concurrently, the rates, well, you know, those are not very big trials, but it's already, you know, the rates of pneumonitis grade 3 is about 10% in most of the cases. Grade 2 plus grade 3 is about 15 to 20%. So, I mean, I think that is a rate that is reasonable, particularly that, you know, you have to follow up your patients very carefully. And the important thing is that if the patient is developing toxicity, you actually early diagnose it and early treat it. So I don't think at the current stage you are having big issues with that. The good thing is that apart from the only trial with one of the arms in the Pembro trial, for most of the cases, we haven't seen an increase in toxic deaths with chemoradiation. And I think this is really, really important. The more relevant issue is going to be for the less fit patients, particularly those with big central tumors where toxicity-wise, you may run into issues.
Maybe I can add to the durvalumab. There was a Pacific R study. We've submitted an abstract where they looked at in Europe or worldwide how long the time was before the durvalumab was started, and then you elegantly showed that within 14 days is the best. Well, there was a variation up to 9 months after stopping the systemic radiation therapy. So we can do a lot better, I think. The organization must be improved. So I had a question for Shiresh, if I may. Now, so if you find a major pathological response, would you think that in the near future, after the surgical resection, you would like to go on with your immuno and get rid of the chemo, or would you let that depend on circulating tumor DNA?
Yeah, I think I did not get into it because I did not have time. I suspect that we are going to use more and more biomarkers, such as circulating tumor DNA, to define post-operative therapy, irrespective of whether patients got neoadjuvant therapy or not. So a baseline ctDNA analysis, and if positive, whether you clear it after surgery or after neoadjuvant treatment and surgery, may help us define. It's speculative clearly right now. There are indications from trials, including the Empower 110 trial, that there may be benefits, that is, patients who clear ctDNA appear to have better outcomes. So I completely agree that that is going to define. I thought you were going to ask a challenging question as to patients who have sort of less than MPR or even MPR, but not pathologic response. Is there any benefit of continuing treatment, or giving more cycles of chemo IO or IO alone? And that remains a huge question mark. In most of the studies, adjuvant therapy was somewhat optional, and even if it was mandatory, it was, you know, up to the investigator as to whether they wanted to do that or not. So I think biomarkers are going to be very critical in defining patients, both for adjuvant therapy in general, but more importantly, which patients to use immunotherapy.
Well, I think that I would like to thank the speakers and all the participants to this very interesting session. And we have a very good comprehensive review of all the problematics